Welcome to the deep dive. Today, we're going a bit deeper than usual aches and pains. We're exploring how your actual DNA can affect your blood vessels.
That's right. We're looking specifically at aneurysms caused by inherited connective tissue problems, drawing heavily from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. Some really detailed chapters in there.
Okay, so what's our mission today? What are we trying to get out of this?
Well, the goal is really to understand the genetic side of things, what makes these conditions tick, and importantly, how doctors approach treatment. It's about using that fundamental understanding to guide, actual medical care.
Got it. So let's unpack the basics first. Connective tissue relies on key proteins, right? Like collagen and elastin.
Absolutely. Collagen and elastin are crucial for our blood vessels. Think of them as the scaffolding and the elastic bands that keep arteries strong but flexible. Table 141.1 in Rutherford's really drives home their importance.
And the conditions we're discussing today, they happen when there's a problem with the genetic instructions for these proteins.
Exactly. A genetic glitch, if you will. And if the instructions for making collagen or elastin are faulty, the blood vessel walls themselves can be weaker from the start.
Which opens the door to things like aneurysms, those bulges.
Precisely. Aneurysms or even dissections, which are tears within the wall, and the most dangerous outcome, rupture.
Now, just to be clear, we're not talking about inflammatory conditions here. Things sometimes called collagen vascular diseases.
Good distinction. No, those usually involve the immune system attacking tissues. That's a whole different topic.
Okay.
Today, we're zeroing in on 4 specific heritable disorders. Marfan Syndrome, or MFS.
Okay.
Vascular Ehlers-Danlos Syndrome, which you'll often hear called VEDS.
VED.
Loeys-Dietz Syndrome, or LDS.
ALF.
And finally, Familial Thoracic Aortic Aneurysm and Dissection. Shorten that to TAYAD.
TAYAD. Got it. 4 key players. So, where should we start? Marfan.
Makes sense.
Yes.
Let's kick off with Marfan Syndrome, named after Antoine Bernard Jean Marfan, a French pediatrician.
He first described it way back, didn't he? Like 1896.
He did. He described a young patient with unusually long limbs. But interestingly, the full picture, especially the vascular part, the aortic problems, wasn't really appreciated until much later. Around 1943, actually, after Marfan himself had passed away.
Huh. Shows how understanding evolves, doesn't it?
It really does, especially with these complex genetic conditions.
So how common is Marfan syndrome?
The estimates usually hover around 2 to 3 people per 10,000, but there was a study in Scotland suggesting it might be closer to 1 in, like 9,800 births.
So potentially underestimated.
Could be. Some features become more obvious with age, so earlier figures might miss some cases.
And how does it get passed down?
It's typically autosomal dominant, meaning if one parent has it, each child has a 50-50 chance of inheriting the gene mutation.
But not always inherited.
Right. About a quarter of cases are de novo new mutations that appear spontaneously in someone with no family history. And it affects men and women equally.
Okay, this is interesting. The source mentions a higher rate in athletes, like basketball and volleyball players.
Yes. That's likely tied to the characteristic tall, slender build. The term is dolichostenomelia. It gives them an advantage in those sports.
So they're more likely to have it, or just more likely to be noticed because they fit the profile and are getting screened?
Probably a bit of both. But there was a screening study that found aortic root enlargement in 1% of athletes screened, and 2 were actually diagnosed with Marfan. So it's definitely present in that population.
And historically, the outlook wasn't great.
No, definitely not. Life expectancy used to be drastically shortened. The average age of death was around 38, mostly due to cardiovascular issues like aortic rupture or dissection or valve problems.
But that's changed.
Massively. This is a key point. Advances in diagnosis and, crucially, treatment, both medical and surgical, have improved life expectancy dramatically. It's now approaching near normal levels for many people with Marfan.
That's incredible progress. So what's actually going wrong at the tissue level?
Early on, scientists suspected an issue with elastic fibers. But the elastin gene itself didn't explain the whole syndrome. The breakthrough really came with understanding microfibrils.
Microfibrils.
Yeah, tiny, tiny structures like 10 to 14 nanometers across, found in all connective tissues. They're like a reinforcing mesh.
Okay.
And then Sakai and her colleagues identified the main protein component of these microfibrils, fibrillin-1 or FBN1.
And that's the Marfan gene.
That's the one. They mapped the Marfan locus to chromosome 15q21.1, and mutations in this FBN1 gene are the underlying cause. It's inherited in that autosomal dominant way we talked about.
So what does fibrillin-1 normally do?
It's a huge glycoprotein, really vital for tissue homeostasis. Postnatally, after birth, these microfibrils are essential for maintaining normal elastic fibers if they're disrupted because of faulty fibrillin.
The aortic wall gets weaker.
Exactly. The aortic wall homeostasis is perturbed. You get inflammation, calcification, the structure becomes disorganized. That's the cystic medial necrosis you hear about. Figure 141.1 in the book shows this quite clearly with staining. It weakens the whole structure.
But there's more to it, isn't there? Something about TGF-beta?
Yes, this was another major piece of the puzzle. Microfibrils don't just provide structure. They also regulate signaling molecules, including transforming growth factor beta or TGF-beta.
How does that work?
Well, FBN1 actually has similarities to proteins that bind to TGF-beta in its inactive or latent form. Normally, these latent TGF-beta complexes are kind of stuck to the microfibrils, sequestered away, so they can't signal.
Okay, like keeping it locked up?
Precisely. But in Marfan, with faulty microfibrils, you don't have enough proper storage sites. So more TGF-beta is free and active, leading to over-signaling.
And that explains other Marfan features, not just the weak aorta.
That's the thinking, yes. It helps explain things like the overgrowth of long bones, the tall stature, the specific craniofacial features, even muscle underdevelopment. Figure 141.2 gives you a visual. It's not just structural failure, it's also this signaling pathway gone awry.
Fascinating. So clinically, it's a multi-system thing.
Absolutely. Cardiovascular, ocular eyes,
Yeah.
skeletal. It affects people globally, no gender or race spared. But the biggest life threat remains that aortic root aneurysm and the risk of dissection or rupture.
How is it diagnosed now? You mentioned criteria.
Yes, the Ghent criteria. They've been revised over the years 1986, 1996, 2010, largely reflecting the advances in genetic testing.
So genetics play a bigger role now.
They do. The latest criteria really emphasize major features, like the aortic root aneurysm, lens dislocation, that's ectopia lentis, and finding an FBN1 mutation. Sometimes these carry more weight than just counting skeletal features. Box 141.1 lays this out.
So it's a mix of clinical exam and genetic testing.
Exactly. A good clinical assessment based on the Ghent criteria is still vital, but genetic testing, especially with next-gen sequencing, can pick up very subtle mutations, confirming the diagnosis. And once someone's diagnosed, screening first-degree relatives is really important.
Are there other conditions that look similar? Things that could be confused with?
Yes, differential diagnosis is key. There's something called the MAS-S phenotype.
MAS-S, what does that stand for?
Mitral valve prolapse, myopia, mild aortic root dilation, striae, stretch marks, and mild skeletal changes. These folks sometimes have specific types of FBN1 mutations too.
Okay, what else?
Schwinson-Goldberg syndrome. That involves craniosynostosis, skull bones, fusing early facial differences, chest issues, long fingers, and aortic root dilatation. Developmental delay is more common there than in Marfan. Mutations in SGI or FBN1 can cause it.
Any others?
Homocystinuria can cause tall stature and lens dislocation, but not typically aortic enlargement.
Yeah.
Blood tests show high homocysteine levels. Then there's congenital contractural arachnodactyly, or CCA. Yeah, shares the long fingers and toes, but no major eye or heart issues typically. It's caused by FBN2 mutations, a different gene. Physical therapy is key for CCA.
So once you have a Marfan diagnosis, what's the follow-up?
Regular monitoring is crucial. Annual eye exams with a slit lamp, cardiac imaging, usually echocardiograms to watch that aortic root, and orthopedic checks for scoliosis. Our focus here is really on the vascular side, though.
Right, the aorta, that's the big worry.
It is. Aneurysm and dissection risk goes up as the root dilates. And since this dilation can start even before birth, you need lifelong echo monitoring.
What if the echo isn't clear?
Then CT or MR angiography gives a more detailed look.
Are there specific size targets for surgery, especially in kids?
It's trickier in children. There aren't absolute size thresholds like in adults, but rapid growth, say, more than a centimeter a year or significant leakiness of the aortic valve might push towards earlier surgery. Doctors use Z-scores. Yeah, they compare the child's aortic size to the average for their age and body size. A rapid increase in the Z-score, maybe jumping 2 or 3 standard deviations, could justify repair.
And in adults?
Generally, repair is recommended when the aortic root hits 50 millimeters or 5 centimeters. But if there's a family history of dissection at smaller sizes, surgery might be considered sooner, maybe around 4.5 centimeters.
What about prevention, lifestyle changes?
Yeah, important stuff. Avoiding activities with sudden, intense exertion or Valsalva maneuvers like sprinting, heavy lifting, basketball, soccer.
So what can you do?
Sports that are more stable and consistent are generally better. Jogging, biking, swimming. Less jarring, less sudden strain.
Let's talk medical treatments. Beta blockers are standard, right?
They have been, yes. Drugs like propranolol or atenolol. The idea is to slow the heart rate and reduce the forcefulness of the heartbeat, decrease what's called DPPT, and shear stress on the proximal aorta. Target resting heart rate often under 70, exercise under 100.
And do they work?
The early propranolol trial showed they did slow aortic growth and reduce events, yeah. But the response wasn't as good in heavier patients or those who already had quite large aortas when they started.
What about Losartan? That came later.
Yes, Losartan is an ARB and angiotensin receptor blocker. It gained traction based on studies in mouse models of Marfan, where it seemed to inhibit aneurysm growth by affecting that TGF pathway we discussed.
So, targeting the underlying mechanism more directly.
That was the hope, and a big multi-center trial compared Losartan to beta blockers in kids and young adults.
What did it find?
Essentially, it found Losartan was equivalent to beta blockers in slowing aortic root growth over 3 years. Some other data, more retrospective, hinted Losartan might reduce the risk of type B dissections too.
So which one is better?
Right now, there's no strong recommendation favoring one over the other. Often it comes down to individual tolerance, side effects, patient preference. One thing to note, calcium channel blockers are generally avoided.
Why is that?
Some evidence suggests they might paradoxically accelerate aneurysm growth in Marfan. So, best to steer clear.
Okay, so if medical therapy isn't enough or the aorta reaches that threshold, it's surgery. 5 centimeters is the usual trigger for the root.
That's the traditional threshold for prophylactic aortic root repair, yes. And importantly, repairs aren't just limited to the root. People are living longer, so repairs further down the aorta are happening with pretty acceptable outcomes. Figure 141.3 shows the distribution.
And the thresholds for, say, the arch or the descending aorta?
Generally a bit larger, similar to thresholds for atherosclerotic aneurysms, maybe 5.5 to 6.0 centimeters.
What about the thoraco-abdominal aorta? The part through the chest and abdomen?
Dr. Crawford did the first successful repairs there in Marfan patients back in the 80s. Elective repairs there benefit from all the refinements made to reduce spinal cord injury risk, just like in non-connective tissue disease cases.
Same thresholds, 5.5 to 6.0 centimeters.
Generally, yes, or symptoms develop. The repairs in Marfan patients often need to be more expensive, though.
Why more expensive?
Often because the underlying issue is a chronic dissection, not just a simple bulge. Maybe 40–80% of these thoraco-abdominal repairs in Marfan are for extensive DeBakey type 2 patterns.
Does that increase risks, like paralysis?
Interestingly, when you match for the extent of the repair, the rates of paraparesis or paraplegia seem comparable to non-connective tissue disease patients. And long-term survival is often better in the Marfan group, likely because they're younger at the time of surgery.
Do they often need more surgery later?
Actually, after a big type 2 thoraco-abdominal repair, the rate of needing further aortic repair is relatively low, simply because there isn't much native aorta left.
But complications can still happen with the repair itself.
Yes. Secondary procedures might be needed for things like pseudoaneurysms or issues with surgical patches used to reconnect visceral arteries, the arteries to the gut and kidneys. Visceral patch aneurysms are a known issue. Figure 141.4 shows an example.
So what's the solution to patch problems?
The trend now is to limit or avoid those big patches. Instead, surgeons prefer using branched grafts, direct anastomosis basically. Figure 141.6 illustrates that. Connecting each vessel individually seems more durable.
Can you get patch aneurysms elsewhere?
Yes, intercostal patch aneurysms can happen too. Treating those with stent grafts is sometimes considered, but the risk of paraplegia is high. Usually, patch aneurysms are repaired if they get to about 6 centimeters because the repair itself carries risks.
What about endovascular treatment stent grafts in general for Marfan aorta?
Generally not recommended for the main thoracic or abdominal aorta. There's just not enough data in this specific population with fragile aortas. There are real concerns about the outward force of the stent graft long term. Figure 141.5 highlights potential issues.
So never used.
It's mostly reserved for very specific late problems like a localized pseudoaneurysm or maybe bridging between previous grafts. The emerging series show pretty high failure rates, unfortunately, and high mortality with those failures.
What kind of failures?
Retrograde dissections, where a tear propagates backwards towards the heart, are a big concern, especially after TVAR, thoracic endovascular aortic repair. If you do use a stent graft, avoiding oversizing is critical. But generally, open surgery remains the standard for primary repairs in Marfan.
Okay, let's switch gears. Vascular Ehlers-Danlos Syndrome, VEDS. This is different from Marfan, right?
Very different. EDS itself is a whole group of disorders affecting connective tissue, joint hypermobility, stretchy skin. Tissue fragility. VEDS is a specific and particularly serious subtype
Why is subtyping so important?
because the natural history and inheritance patterns vary hugely. Classic EDS types I and II are more common and generally less severe systemically than VEDS. Older literature sometimes mixed them up, which was misleading. We now know VEDS needs to be considered separately.
How common is VEDS?
It's rarer than Marfan. Prevalence is estimated around 1 in 50,000 to 1 in 90,000. It's also typically autosomal dominant.
So 50-50 inheritance risk.
Yes, but like Marfan, about half the cases are new mutations. A key thing about VEDS is the gene involved, COL3A1.
COL3A1, what does that make?
It provides instructions for type 3 procollagen. This type of collagen is a major component of skin, hollow organs, and especially blood vessel walls.
And that's the problem in VEDS.
Exactly. Mutations in CO3A1 lead to faulty type 3 collagen, and this has devastating consequences for life expectancy.
How bad is it?
Significantly shortened. The median lifespan is only about 48 years. Complications are rare in childhood, but by age 20, a quarter have had a major issue, and by 40, it's almost 90%.
What kind of issues?
Mostly vascular, GI, or reproductive problems. The main cause of death, around 60%, is rupture of thoracic or abdominal blood vessels. Also intracranial bleeding, organ rupture, bowel rupture. It's a very fragile situation.
So the COL3A1 mutation, how does it cause such weak vessels?
Type 3 collagen needs to form a stable triple helix structure. The mutations in VEDS disrupt this. The abnormal protein often can't fold correctly.
So it just doesn't work.
Worse than that, often. It can get degraded inside the cell or even interfere with the normal protein produced by the good copy of the gene. This idea is sometimes called protein suicide. Even having one good gene isn't enough.
Does the type of mutation matter?
It seems to, yes. Certain mutations, like those causing glycine substitutions within the collagen chain, tend to be associated with a more severe phenotype and shorter survival compared to mutations that simply lead to less protein being made. Haploinsufficiency. Figure 141.7 shows Kaplan-Meier survival curves illustrating this.
Okay. Clinically, how do you spot VEDS?
It has the worst prognosis of the EDS types, so diagnosis is critical. Box 141.3 lists the criteria. Things like thin, translucent skin where you can easily see the veins, very easy bruising, characteristic facial features.
What kind of features?
Often thin nose and lips, prominent eyes, hollow cheeks, small chin, and crucially, a history of arterial rupture or dissection, bowel rupture, or uterine rupture during pregnancy. Having 2 or more of these major criteria is highly suggestive.
So testing is needed?
Absolutely. Biochemical testing looking at collagen produced by skin cells used to be the standard, but now direct genetic testing for COL3A1 mutations is increasingly the way to confirm the diagnosis.
What else could it be confused with?
Well, the easy bruising could make you think of bleeding disorders like von Willebrand disease or even scurvy. In kids, sadly, non-accidental trauma has to be considered, though vascular ruptures tend to be in medium-sized arteries, unlike Marfan's focus on the aorta.
Any other overlaps?
Vessel tortuosity might resemble LDS or arterial tortuosity syndrome, but surgery is usually tolerated better in those. Multiple visceral aneurysms could suggest polycystic kidney disease. Varicose veins are common, but not specific.
Is there any specific medical treatment for VEDS itself?
Unfortunately, no cure or specific therapy that targets the underlying collagen defect. Management is really about knowing the diagnosis, genetic counseling, managing complications, and taking precautions.
Precautions like what?
Medical alert bracelets are essential, and if surgery or procedures are needed, extreme care is required. Specific anesthesia recommendations exist, having blood ready, avoiding injections into muscle, careful IV access, maybe using ultrasound for lines, gentle intubation. The tissues are just so fragile.
What about aneurysms in VEDS? Are they common?
True aneurysms are actually less common than you might think, maybe 14% in one series. Spontaneous bleeding into tissues is more characteristic.
How is bleeding managed?
Conservatively, if possible, especially if it's interstitial, within the tissue layers. If there's bleeding into the abdomen, transfusions might be needed. If surgery has to be done to stop bleeding, simple ligation tying off the vessel, often with soft umbilical tape, is generally safer than trying a complex repair on tissue that just won't hold stitches well.
So direct repairs are risky.
Very risky.
Yeah.
If attempted, they need to be tension-free, reinforced with pledgets. Figure 141.8 shows this, and diagnostic angiography. Usually avoided.
Why avoid angiography?
High risk of causing a dissection or perforation with a catheter or contrast injection. Studies showed complication rates over 60%, even deaths. Newer, smaller catheters might be safer, but it's still a concern.
What's the general approach to vascular surgery then? Avoid it.
Historically, yes. The mantra was avoid surgery unless death was imminent. But experience from centers like Johns Hopkins suggests maybe a slightly more proactive approach could be better in select patients.
Select patients.
Yeah, perhaps those who haven't shown extreme fragility in prior events. If someone is very young or has multiple other fragile areas, the risk might be too high. Spontaneous abdominal bleeding without a clear source is a very bad sign.
What about non-vascular issues? You mentioned bowel rupture.
Yes, spontaneous GI perforations happen in about a quarter of patients, often in the sigmoid colon. Prompt surgery, usually creating a colostomy, is needed. Small bowel ruptures might also need a temporary ostomy, and pregnancy carries very high risks for uterine rupture in vascular events.
Any medical treatments tried? You mentioned beta blockers.
Celiprolol, a specific beta blocker, was studied. One trial in France suggested it reduced vascular events, but the trial had limitations, like not everyone having genetic confirmation. Plus, a mouse study showed increased mortality with it. So it's not FDA approved or widely recommended right now.
So what is recommended medically?
Mainly supportive care. Good blood pressure control is vital, often using other beta blockers or ARBs. Managing cholesterol with statins if needed. Avoiding calcium channel blockers based on detrimental effects in mouse models, and lifestyle mods similar to Marfan, avoiding high-impact restraining activities.
Surgical repair sounds incredibly challenging.
It is. Formidable is the word Rutherford uses. The arteries are diffusely affected, as you see in Figure 141.9. The traditional approach was hands-off unless absolutely necessary.
But the Johns Hopkins experience suggested elective might be better sometimes.
Their series showed better outcomes with more elective repairs compared to the Mayo Clinic series, which was mostly emergencies. It hints that intervening before rupture might be worthwhile in some carefully chosen patients. Table 141.3 compares these series.
What techniques help?
Meticulous technique is key. Liberal use of tissue reinforcements. Very gentle clamping with padded clamps, maybe allowing lower blood pressure during critical parts of the surgery, permissive hypotension, to reduce stress on suture lines.
Anything unique about the aneurysms themselves?
Sometimes you see these bell-bottom iliac aneurysms. The common iliacs balloon out, but the aortic bifurcation itself is relatively spared. Figure 141.10 shows this. Elective repair might be considered for these in younger patients, using those reinforcing techniques.
It sounds like a really tough judgment call every time.
Absolutely. Risk-benefit is crucial. Genetics might offer some clues. Maybe those with haploinsufficiency mutations handle surgery better. But clinical history, early onset, severe features, prior complications is probably the best guide to the expected surgical risks. And older patients tend to tolerate procedures less, while as fragility worsens.
What about endovascular options in VEDS? Coils? Stents?
Coil embolization can be very useful for bleeding from smaller branch arteries, like in the spleen or liver after spontaneous tears. It seems relatively safe for that.
But getting access for endo procedures, still risky.
Access site complications, femoral artery rupture, pseudoaneurysm are definitely a concern, especially with larger devices. Sometimes open repair of the puncture site itself is needed. Figure 141.11 illustrates this.
And stent grafts for aortic aneurysms.
Not really reported much in VDS. Big concerns about long-term durability and stress at the landing zones in such fragile tissue, so generally avoided like in other connective tissue diseases.
Any specific VEDS complication treatable with endo?
The carotid cavernous sinus fistula, an abnormal connection near the eye, shown in Figure 141.12 as a classic VEDS issue. Coil embolization can be effective for that in selected cases. Okay, moving on to Loeys-Dietz Syndrome, LDS. This one's newer on the scene, relatively speaking.
Newer. What defines LDS?
It's characterized by a combination of aortic aneurysms, vascular tortuosity, twisty arteries, and specific craniofacial features. Think bifid uvula or cleft palate, and widely spaced eyes, hypertelorism. Box 141.4 lists more features.
And it's genetic, too.
Yes, caused by heterozygous mutations, but in genes related to the TGF-beta signaling pathway, similar pathway to Marfan, but different genes.
Which genes?
TGF-br1, TGF-br2, SMAD3, TGF-b2, TGF-b3. These define 5 subtypes, LDS-I through V, with somewhat varying features. LDS-I and II are known for particularly aggressive aortic disease.
Aggressive how? Worse than Marfan.
The main issue is the aggressiveness of dissection and rupture. It often happens at smaller aortic diameters than in Marfan and can even occur in childhood. This makes early identification and family screening absolutely crucial for timely prophylactic surgery.
Are there differences between the subtypes?
Early comparisons suggested LDSI might be more aggressive than LDS2, with earlier death and earlier first surgery on average. And severity of craniofacial features seemed to correlate inversely with age at first surgery, more severe features, earlier surgery needed. LDS 3rd and 4 might have a later onset.
Clinically, what does LDS look like?
It's multi-system. The classic triad craniofacial abnormality, hypertelorism, and arterial tortuosity aneurysm is seen in almost all patients. Lots of other potential skeletal and skin findings, too. Developmental delay isn't usually a primary feature, though.
Does it only affect the aorta?
No, and that's important. While the aortic root is often involved, aneurysms can occur throughout the vascular tree. Sometimes patients present first with a non-aortic aneurysm. That's why head-to-pelvis imaging is needed at diagnosis. Figure 141.15 shows common spots.
What are the key facial features again?
Hypertelorism, wide-set eyes, and cleft palate or bifid uvula are the most common. See Figure 141.13. Craniosynostosis, malar hypoplasia, flat cheekbones, blue sclerae can also occur. But notably, unlike Marfan, lens dislocation isn't seen in LDS.
And the twisty arteries?
Arterial tortuosity, especially in the vessels of the head and neck, is a big clue, particularly for LDS3. You really need 3D imaging to assess how elongated these tortuous segments are. Figure 141.14 shows an example.
What other conditions might be confused with LDS?
Because of the early and aggressive vascular issues, VEDS often comes up in the differential. But distinguishing them is critical.
Why critical?
Because surgical management and tissue handling are very different. LDS tissue, while abnormal, generally handles better surgically than the extremely fragile tissue in VEDS. So recognizing the LDS features versus doing VEDS testing is key.
So treatment in LDS, lower threshold for surgery?
Yes, definitely, given the aggressive nature. For adults, repairs in the thoracoabdominal or infrarenal aorta are often considered at 4.0 centimeters or larger. Table 141.4 gives some thresholds. And remember that full body scan at diagnosis.
Any other surgical considerations?
The tortuous supraaortic vessels can sometimes complicate surgical exposure. Embolization might be needed beforehand, and patients often need multiple interventions over their lifetime because the arterial disease is widespread.
What about medical treatment for LDS?
Recommendations currently lean on the Marfan playbook. Beta blockers are often used, but again, with that lower threshold for surgery.
Does Losartan help, given the TGF-beta connection?
Theoretically, it makes sense, and it's sometimes used based on the Marfan mechanism. But there aren't large randomized trials in LDS specifically, and preliminary data hasn't been conclusive. So, still an area of research.
Lifestyle restrictions.
Similar to Marfan. Avoid burst activities, contact sports, heavy isometric exertion. Protect those vessels.
How does the tissue hold up during surgery? Better than VEDS?
Generally, yes. Early surgical reports suggest tissue handling and creating anastomosis connections are more favorable in LDS than in VEDS. Aortic root replacements have had good initial results, though late ruptures elsewhere can still happen.
Any specific techniques favored?
Similar to the trend in Marfan, experience suggests limiting or avoiding those inclusion patches for visceral arteries. Direct anastomosis with branched grafts is preferred. Figure 141.16 shows this.
So general surgical thresholds for LDS?
For any aortic segment in adults, the recommendation is often repair at 4 to 5 centimeter diameter, or if it grows more than 0.5 centimeters in a year. Box 141.5 summarizes vascular care guidelines. Decisions for peripheral aneurysms depend on age, size, growth rate, so regular, high-quality imaging is vital.
Does the tortuosity itself cause problems?
It can progress, but dissection or degeneration right at the hairpin turns doesn't seem to be a common feature, thankfully.
Okay, one more category. Familial thoracic aortic aneurysm and dissection, or TAYAD.
Right, this isn't a single syndrome like Marfan or LDS. It's a term for families where TAYAD occurs without the obvious features of those other syndromes.
So just the aortic problem, but it runs in the family.
Essentially, yes. Minimal outward signs, but a strong family history of aortic events. Studies suggest maybe 11–19% of people with apparently sporadic TAYAD actually have an affected first-degree relative.
How is it inherited?
Usually autosomal dominant, and this is key with decreased penetrance and variable expressivity. Decreased penetrance means not everyone who inherits the gene variant actually gets the disease. Variable expressivity means those who do get it can have very different severity or presentations. This makes it clinically tricky. Genetic mapping is helping us understand the pathways involved. Researchers have found several genetic loci linked to familial TAYAD and identified some specific genes. But the common endpoint seems to be this medial degeneration in the aortic wall. Smooth muscle problems, matrix changes.
Any specific genes identified?
The first locus mapped was TAY1 on chromosome 5. Another important one is mutations in ACTA2, the gene for smooth muscle alpha axon. These account for maybe 14% of familial TAYAD.
Is ACTT disease different?
The aortic tissue shows cystic medial degeneration, but also smooth muscle proliferation. Interestingly, the penetrance for ACTA2 mutations isn't super high and doesn't seem strongly age-related, unlike some other TAYAD genes. It highlights that aortic disease can be quite localized sometimes.
So what's the common thread with these genes?
They all seem to relate to the aorta's structural integrity and how it responds to mechanical stress. Mutations might mess up the normal mechanosensing, leading to maladaptive changes that weaken the wall.
How do these patients typically present?
They often present at a younger age than people with sporadic thoracic aneurysms, average late 50s versus mid-60s, suggesting a more aggressive process. Thoracic aneurysms are most common, but abdominal and even cerebral aneurysms can occur in these families too.
Aneurysm versus dissection.
In the ascending aorta, aneurysms seem more common. In the descending thoracic aorta, it's maybe a 50-50 split between aneurysm and dissection presentation.
How does treatment differ for familial TAYAD?
It's complicated by that variable penetrance and expression, and we don't have great genotype-phenotype correlations yet.
So how do you decide when to operate?
In families with a really aggressive history, like dissections happening at small aortic sizes, you might lower your threshold for surgery, considering the family pedigree more than just absolute size. For those with less dramatic family history, standard thresholds, like 5.5 to 6.0 centimeters for thoracic, maybe 5.5 centimeters for AAA, might apply.
Do they grow faster?
There's evidence that thoracic aortic growth rates are higher in familial TAYAD compared to sporadic cases, averaging about 0.21 centimeter versus 0.16 centimeter.
Endovascular options, stent grafts.
Generally not reported or recommended for familial TAYAD, similar to the other connective tissue disorders. The concerns about aortic wall weakness and fragility are paramount. The consensus is really against using endovascular approaches as primary treatment here. And just to mention, the Rutherford's chapter does provide a useful algorithm, a kind of flowchart for evaluating patients when you suspect a connective tissue aortopathy. It helps guide the workup.
That sounds helpful. Any key papers people should look up if they want to read more?
Definitely. The chapter highlights several, including work by Habashi on TGF-beta and Losartan in Marfan, Loeys on LDS natural history, Pepin on VEDS clinical features. These are really foundational papers in the field.
Okay, so let's try to wrap this up. What's the big picture takeaway from this deep dive?
I think the main point is that these heritable connective tissue disorders significantly impact vascular health. They lead to aneurysms and dissections through very specific genetic pathways and distinct ways the tissue fails.
And management depends heavily on knowing which disorder it is.
Absolutely. Early, accurate diagnosis is key. Then comes careful surveillance and tailoring the treatment, medical and surgical, to the specific condition, like Marfan versus VEDS versus LDS or familial TAYAD. That tailored approach is crucial for improving outcomes.
Understanding the specific genetics really guides everything.
It does. It helps predict risks, inform surgical decisions, guides family screening. It's central to managing these complex patients effectively. Each one presents unique challenges.
Okay, final thought to leave our listeners with. We're seeing huge advances in genetic testing and understanding these diseases at a really fine-grained level.
Yeah, the pace is incredible.
So how might personalized medicine, really tailoring treatment to someone's specific genetic profile and maybe even their specific mutation, change how we manage these heritable aortic diseases down the road?
That's the big question, isn't it? The potential is enormous, but there are practical and ethical considerations too. It's definitely something to think about as the science continues to evolve. How specific can we get, and how much difference will it make? Fascinating stuff.